Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I'm one of Team MMOA, and today is Wednesday, so we are talking all things Geri on Ice. A couple of weeks ago, I started part one of this series around constipation in older adults. And so in part one, we went through why rates of constipation drastically increase as we get older and why it's really important as physical therapists, as occupational therapists, as people in the rehabilitation space that we want to address, talk about, or at least be aware of issues with constipation in our older adults. Today, what we're going to do is we are going to talk about management. When I talk to geriatric clinicians, oftentimes they feel like they don't have the confidence because they haven't taken a bunch of courses in pelvic health. And I want to kind of, remove that as a prerequisite to talking about bowel and bladder dysfunction. If you start talking about bowel and bladder and all of a sudden realize that, wow, this is something really impactful, which it is. We have pelvic floor courses, but that is not a prerequisite for chatting about this with your clients. So the way that I want to break this down is around education and then physical intervention. We always say that you never, ever, ever want to underestimate the power of your education. And in our pelvic division, we say, as a culture, as a society, we are unfortunately so undereducated about our own bodies. And we can maybe assume that as people get older that they learn more about their own anatomy, their own function, but that is not the case. And oftentimes people feel embarrassed talking about peeing and pooping, especially when they don't want to be peeing and pooping. And it's a very sensitive part of the body, right? So it can be difficult for people to know who to talk to. And unfortunately, there's a lot of dismissal that can happen with medical providers when trying to approach these really kind of embarrassing and uncomfortable conversations to talk about. Kind of going into this education umbrella, the first thing is that you can educate one on bowel and bladder function, right? Ideally, we should be having 2 bowel movements a day to a bowel movement every 2 days as our bunker. Sometimes they will expand that out and it can be every couple of days, but from my clinical experience and people's comfort level, if you are not pooping every 2 days, you are probably experiencing some of the discomforts of constipation, right? Trying to go to the bathroom and not being able to, straining, having the urge and feeling like there is rectal bulk, abdominal pain, achiness around the low back. Like if you are going 3-4 days without pooping, you're starting to get uncomfortable. Okay. So first saying, hey, like our ideal optimal zone is I would love for you to be pooping every day, worst case every 2 days. And if you poop more than that and it's solid and it's not diarrhea, like that's where we want to be. The second thing is around consistency of stool. The Bristol stool chart is a kind of a chart from constipation to diarrhea. And what we want to know is, do they have normal stool that's soft, that looks sausage-like, that isn't diarrhea or very loose? Because that's when like you never want to trust a fart, because that can be very, very hard to close the anal sphincter to prevent leaking of contents and therefore liquid fecal incontinence. And we don't want it to be like rabbit poop, like tiny little pebbles, because that's signs of dehydration. It's also signs of constipation. And so we may take out the Bristol stool chart and say, kind of tell me on this continuum from the type 1s, which are constipations, to lower levels, which are diarrhea, where are you? And if they're kind of in that constipation area on the Bristol stool chart, then we'll kind of go a step further. Then from our education perspective, if we know how often they're going to the bathroom and what their type of stool looks like, then the next thing that we can do is teach around what the bowel and bladder does and how the pelvic floor contributes to it, right? Again, you don't need specialized training, but we want our clients to know that our pelvic floor relaxes to essentially unkink our hoses, which is our urethra if we're peeing, our anal sphincter if we're pooping. And when we unkink that anal sphincter, it allows for stool to evacuate. So learning about the pelvic floor and say, hey, did you know you have a set of muscles down there? It helps us to be able to relax those muscles in order for us to be able to poop when we want to be pooping. Let's chat about that. The second thing is that having constipation, we want to bridge this to nutrition, right? Nutrition is hugely important. It is hugely important across the life continuum, but we see a higher rate of dehydration in our older adults. A variety of reasons. If individuals have pelvic floor dysfunction, they may be dehydrating themselves. Also, our thirst drive and our sensation when we are dehydrated is less sensitive as we get older. Therefore, you are getting that drive, oh, I should probably drink some water later in our dehydration process. And individuals may not have access to as much, if they have mobility concerns, for example, they may not be getting up as often, even if they have the drive for thirst, to be hydrating themselves. So if individuals are in that, hard, lumpy stool category, we may be educating on hydration. We may be looking at or getting them to take us through a day in their life when it comes to what they are eating. We may be linking with our registered dietitian staff in hospital, or, with if you're in a senior nursing facility or a wellness retirement home or in a long-term care home, and see, what are your older adults eating? Are there things that are constipating for them? I know a lot of people will joke that, a lot of dairy foods can constipate them. So trying to figure out what their triggers are from a nutrition perspective, and ensuring hydration is a very important part of education when it comes to working with older adults that are constipated. And again, a lot of low-hanging fruit around kind of basic nutritional counseling. The last kind of bucket within the education sphere, right? So we want to teach about how our bowel and bladder functions, what our normal kind of frequency of bowel evacuation should be, what our consistency of our stool should look like, how our pelvic floor contributes to that, and how nutrition contributes to that. Our final kind of layer in this educational bucket is medication. We are seeing so many of our older adults with multimorbidity. They are on a laundry list of different medications. They all have side effects. There are plenty of classifications of meds that have constipation as a issue. For example, our antimuscarinics, so that are medications that are our second line of treatment, but our first line of pharmacological treatment is anticholinergic, and its biggest side effect is constipation. Opioids and many pain medications have a side effect of constipation. And so going through medications, looking for the classifications of meds that have constipation as a side effect, again, is a way for us to be educating our clients. Did you know that some of this experience that you are having may be due to your meds? We are not changing their meds. We are not counseling on their meds. Maybe we are referring back to see if we can change or augment, because we are now seeing that the side effect profile is significantly impacting a person's quality of life. But it is important that our clients know that this is not something that they did wrong, but that they may be experiencing this because of something else that they're ingesting. Okay, so here's kind of the education piece. Now let's go in and zoom in on the pelvis. Okay, so we have kind of this big overarching lens of education, and never underestimate the power of your education to help a person understand their lived experience. The next one is, let's kind of talk about the pelvic floor. So as I mentioned, our pelvic floor has to contract in order to kink off our hoses so we don't pee and poop when we don't want to be peeing and pooping. On the flip of that, we are going to be relaxing our pelvic floor in order for us to poop. There are a couple of things that can be going on from a pelvic floor perspective that can be causing issues with constipation. So the first one is an increase in range of motion of our posterior vaginal wall in the female pelvis. oftentimes referred to as pelvic organ prolapse. This is when individuals have more movement around the vaginal wall that kind of separates from the rectum. And when there is an increase in range of motion, especially at rest, if this is our vagina and this is our rectum, it can kind of come into the vaginal space. Okay, so the posterior wall can come into the vaginal space. That can cause its own set of sensitization symptoms to the vagina, but from the rectum perspective, it can create this pocket where stool can kind of accumulate, or it can make it that it's more difficult for stool to pass through. So what we're seeing is that some individuals with higher grades of posterior prolapse can also struggle with evacuating stool. What that means is that sometimes they can use, if they have the mobility, this is going to be that concern because you're going to have to splint through the vagina, is placing a pressure from your finger inside the vagina, pushing back towards the butthole and allowing that pocket of space to basically be eliminated. So sometimes that splinting from a pelvic floor perspective can be really helpful. Or if that splinting isn't possible, then potentially exploring using something like a pessary, which is, I talk about it like a bra for the vagina, the bra for the vaginal walls, is it can help place things that have moved across a lifespan, right? So where we can use the pessary potentially, it's a conservative management type of brace to the vaginal wall, is it can kind of unkink and potentially help with some of those bowel symptoms. Those are kind of like static structural pieces. On the other side of the pelvic floor is being able to contract your pelvic floor and relax your pelvic floor. When we talk about the bucket of pelvic floor muscle training, we're often talking about strengthening, especially in the literature, but we would love to expand that definition and talk about the coordination, strength, and relaxation of those muscles. So if they're holding on too tight, then it can be very difficult for stool to pass through. And so we can talk about relaxation, deep breathing to help with that relaxation of the pelvic floor, especially for somebody who has spent a lot of time straining on the toilet trying to evacuate stool. So a different strategy for being able to poop without so much strain on the pelvis. From the level of the pelvic floor, we can kind of expand out to toileting related behaviors, right? So this is where, a lot of our occupational therapists do a very wonderful job. OT and PT together with a constipation management can be super effective. And we want to look at toileting habits. So are they able to get to the bathroom when they have the urge? And that's multifactorial, right? Do they need help from a mobility perspective to get to the bathroom? Are they having a schedule with staff if they do need help? And when they get to the toilet, what does their toilet seat look like? Many of our older adults are using elevated toilet seats from a mobility perspective because they are getting stuck on the toilet. But what that does is it puts them in a more open hip flexion angle, and that impacts the colorectal angle. So if they have to use an elevated toilet seat, I'm not telling them to remove that because they may get stuck on the toilet. But if they're using an elevated toilet seat, then I want to have something to prop their feet up from, right? We have seen a lot in the pelvic health space of things like squatty potties, but it can be a stool, it can be a garbage can flipped backwards, just to elevate their feet in order to get their hip crease a little bit more closed. And that can help evacuate stool, right? So we're going to be looking at, do we need to set up a toileting schedule, a certain amount of time after meals, for example, and make sure that all staff are on board when it comes to that schedule. And then let's look at the transfer to the bathroom. And when they do have to go, are they able to get there independently or with as little assist as possible? We can be working on a lot of those functional transfers, et cetera. And then are they on an elevated toilet seat, and is that impacting their capacity to go to the bathroom? All right, finally zooming out again to overall lifestyle is that exercise is definitely medicine with constipation. And if we have an individual with a high amount of sedentary behavior, it's going to be harder for their bowels to be moving. And so aerobic exercise and getting into more squat angles are ways that can help with pooping. And that can be such a wonderful help to kind of help with bowel and bladder dysfunction. Maybe if your client is having constipation issues and is kind of hesitant to engage in exercise, you can educate on the fact that we do see a positive benefit to exercising on regularity of bowel movements. And so if you can kind of get in on any type of exercise related behavior, it can be super helpful. All right, let's kind of go through those levels. So big overarching umbrella around education, how the bowel and bladder works, how the pelvic floor contributes, what medications may be impacting a person's capacity to go to the bathroom, and from a nutrition perspective, hydration and the foods that are constipating, right? What does that look like? Then we're going to look at toileting behavior. Can they get to the toilet when they need to? Do they have to defer going to the bathroom if they have the urge to have a bowel movement, but they don't have anyone around? Can we set up a schedule with the staff if necessary, if getting to the toilet is something that requires assistance? When they get to the toilet, are they on an elevated toilet seat? Can we elevate their feet? Because oftentimes we're not going to be able to move the elevated toilet seat to get them lower and help with their colorectal angle. From a pelvic floor dysfunction, are they having issues with prolapse? If yes, can we do a posterior splinting technique? If mobility is a concern that is not possible, then can we explore use of things like pessaries to be able to help with constipation? And overarching from an exercise perspective, we know that exercise is medicine and can help with regularity of bowel movements. I hope you all kind of found that helpful. That is a lot of low-hanging fruit that does not require an internal exam, except maybe from the pessary perspective, but you can refer out if you think that they are having bulging sensations around the vaginal opening and it may be contributing. We have so much that we can do, and we talk about all things pelvic health in our MMOA level 2 material. We are done for course offerings for 2024, but we are ready to hit the ground running in 2025. Our first live courses, January 18th, 19th, Dustin is in Hendersonville, Tennessee. February 25th, 22nd, I am in Athol, Idaho. I really hope I pronounced that right. My Canada is showing sometimes. And February 1st and 2nd, I'm in Carson City, Nevada, close to Reno. If you are looking to get into our online material, MMOA level 1 and 2 are starting beginning of January. Level 1 is the 12th. Level 2 is the 8th. Level 1 is the prerequisite to level 2. This is my last podcast of 2024. So have a wonderful holiday season, everybody. We will talk to you all soon. And I hope that you all have a restful and enjoyable time with family, however you celebrate.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.